Thank you so much. I'll start with one question and then turn for everybody. And it's at a somewhat different level. So you've got this universal intervention, which is structured somewhat along the risk levels that are being shown up in there, and hopefully with community agencies that can meet the different risk levels. To what degree is there a conception of parenting and what you're trying to achieve in parenting that underlies what the institutions who are delivering the services are operating from?
Yeah, terrific point. So the Durham Connects program is really based on parenting in the first 3 to 6 months of life. So let's limit it to that. And I would love to be a part of figuring out a universal intervention for 2-year-olds and 3-year-olds and 4-year-olds, et cetera. But think about early life parenting, right? What is our theoretical model about that? There is a set of skills, and important components of providing security, providing warmth, providing positive regard, that Mark talked about a little bit and others have talked about a little bit in early life. So there are skills about that. And then there are also barriers to parents connecting with their babies. Whether the theory is attachment theory fits or skill theory. But then we have a series of barriers to that. Poverty, stressors, family financial stability, lack of access to health care, lack of services to make a healthy parent who's able to parent. So I think the model is both of those. Skills that parents engage in their parenting behavior with their child, but then also these barriers. And so the Durham Connects model is about both of those, trying to understand what the barriers are and cut through those so that parents can connect with their baby.
Great, thank you. Yes.
Hi, I'm Julie Schewel. I'm with the Nemours Foundation, and I'm real interested in your discussions about Medicaid. I think that we are closely tying a lot of health outcomes for children to parenting. And I think we have a potential funding source, as you've identified with Medicaid, also in private insurers. We have a model where we were able to make huge differences in children's asthma by doing parenting intervention and reduced healthcare costs immensely. We can't do it anymore because Medicaid's not going to pay for it. So switching the payment mechanisms towards prevention is a public policy lever that I hope that the committee will continue to think about, because the healthcare systems are freaking out about our costs in the next 10 to 15 years. And a lot of what's scary about it is kids that have significant trauma and significant risk factors that could have been prevented by projects such as Durham Counts. And so I wanted you to talk a little bit more about your thinking around the healthcare system and your conversations with Medicaid.
We need a massive reform. We need a wholly new system. Nobody would have designed our current system at the outset. Our current system is so after the fact, remedial, rehabilitation. The image that comes to my mind is this man at the bottom of a waterfall who's saving all these children after they fall off, right? And building hospitals and patching up their bruises and doing all this after the fact kinds of interventions. That's our social service system. That's our healthcare system for children. That's our system of child development in this country. Right? Instead, we got to get that man up to the top of the waterfall, right? How do we get him up there, right? And I use him because it's really a system that was designed mostly by men. So it's probably going to be a woman who's going to say, get yourself up to the top of that waterfall. But he says, but all the babies are going to die while I'm going up. And so we have a double payment problem for a temporary period of time. We have to continue serving those who are already damaged, whether it's in the foster care system or whatever. We have to do that. But we also have to jumpstart a new system up at the top of the waterfall. So I think we need a double payment for some temporary period of time. And I think that in the long run, we'll save money. Right? The other thing is, frankly, we also have an after-the-fact, politically embedded healthcare and social service system, right? So we have to figure out how to turn those very same people who are providing after-the-fact care into providing preventive care. I live in North Carolina. North Carolina is a tobacco state, right? The problem is you can't stop growing tobacco in this country without harming them. So you have to figure out how to help them be the growers of peanuts or something else in the next wave, right? You can't just say you guys are out of a job. We have to do that with our social service and healthcare system itself. Take those very same people and figure out how to do it. So I think we've got to engineer it a different way. I do think it's going to take a lot of money for a temporary period of time, but that's where I look to Wall Street.
Kim?
Hi, Kim Bowler from Mathematica and the committee. So can you talk about the connects part a little bit more and the infrastructure supports around referrals and the quality of referrals? I know that McVie is really working hard on this and the idea that all the MOUs that are put in place and a service-rich environment versus not. Was Durham sort of a magical place? Was there so much going on there that those referrals worked? So that's one question I had. And then the other one is about follow-ups that you have planned. And how long you'll be able to follow the children.
Yep. The follow-up is easy. As long as we have funding to follow up, we'll try following them up. We have a nice RO1 grant from NICHD to follow them up through the beginning of kindergarten at the moment, so that's where we're at. First part, Durham's not a magical place. I think it can happen in different communities in different ways. We're now disseminating in 4 very rural counties in eastern North Carolina, very different, so it's a different set. One thing I've learned about agencies in Durham that deliver services, right, whether it's professional substance treatment programs for mothers, or parenting support groups, or breastfeeding groups, or welcome baby, or child care facilities that are 5-star or whatever. They all want to serve families, and none of them want to do case finding. And they really don't like bad referrals. And they really don't like no-shows. It costs them money. All right, so we've worked with them, and I said we have 400 of them in our computer bank, right, that we've got full-time people who interact with them all the time, right? In a feedback sort of a system. So we give them good cases, right? So for the substance abuse treatment program, we don't send them cases that are going to be no-show, right? Well, at least we try not to, right? We also try not to send them cases that are inappropriate, right? Psychosis, or the problem's really domestic violence and not something else, right? We train our nurses to match families to cases. The agencies like that, right? So that is a key to it. Another thing is, by having a population approach, we give feedback to the county commissioners about the state of needs. There aren't enough substance abuse treatment beds. You really don't need this because nobody's filling this, right? Change things around. Or what are the barriers? At a very different level. I mean, here's one that I was really gratified to have an impact on. Why mothers weren't going to well baby care from East Durham. Because it was a housing project and the county bus didn't stop there, right? It stopped 1.5 miles away. So we got the bus to stop there, and we got a law change that anybody walking on a bus with a baby gets on free, right? County commissioners could do that for not a lot of money. It improved access. So you got to, I mean, when you're thinking of the whole system, you can do things that help families get connected to community agencies. I think it can happen in any community, however, it's going to be unique. Rural eastern North Carolina is going to be, I mean, it's very different.
This side.
Hi, I'm Porsha Kennel from the Answer Prevention Fund. I'm here with my kitchen cabinet members from Casey Foundation. But I wanted to just make 2 comments and then a question. First of all, I just want to say that I occupy the space of birth to 5 and teaching and learning and family engagement and early childhood and early learning and all of that. But what I want to comment and thank you for is the statement that you made that we have overestimated the capacity of the community to support parents and children. I also want to say we've underestimated the powerful impact that communities could play in supporting parents. In my world, we continue to think the answer lies in a set of interventions that take place in a building or in a classroom. And when parents don't come from a classroom, they come from the community. And when they leave our setting, they go to a community. And what the second comment I wanted to make is to thank you for presenting a systematic view on how to address this challenge for parents and children. It cannot be done by one system or one set of interventions taking place in one building in one community. We really have to, if we're going to support parents, if we're going to support parents as the educators and teachers of their children, the developers of their children, we need a systematic view that involves all the infrastructure systems that touch children and families' lives. And I appreciate you presenting this point of view, because sometimes I get in with my child development people and we get so focused on our piece of the intervention that we forget. And then we are surprised when the intervention, after they've been in a community, doesn't have the impact or the sustained impact that we want. So I thank you for that. So the final question is, can you tell us more about what that system of support and the infrastructure of the various systems that you have in play in North Carolina, and any successful hints about how it might be done in some other places too?
Yeah,
Sorry.
Thank you. Right. We don't have a great system statewide in North Carolina. The state of North Carolina does not know how many 3-year-olds live in North Carolina. We don't have, they have birth records and they have public school enrollments, and in between it's a black hole. There's not a system. We know who's on Medicaid, but you can't really get the population estimate, let alone know what a system of care and supports is in between. So that's what I'm trying to grow. Right? That's what we're trying to do. I'm a clinical psychologist, and I spent a good part of my early career working with individual families. And it was really like hitting my head against the wall, because you're trying to rig the system. You're trying to help a family work the system. And it's very frustrating when you blame the system, right? When you know the system has limits, right? The system that led to the problems is the system that they have to go back to after they leave your clinical psychologist therapist office. So we've got to, I mean, that's why I think we've got to work at the community level and think about it that way.
Yeah, Ken, I was just be curious if I could push you a little further with this fifth point that's still up on the slide around framing. I mean, I think as we write the report, framing is critical, and I'd love to hear lessons learned in your discussions with policy decision makers, if you see some just key pieces of wisdom you'd leave us with on that.
Show me a parent who's successful alone. Anybody who was a successful parent in this room and did it alone, raise their hand. Right? Any parent knows if you're successful, you do it through the grace and help of others. Right? That's the mantra, that's the frame that we give to our county commissioners and our parents. Right? It's not a stigma to have a need for help. Right? Parents think they have to do it alone in some way or another. Young parents, old parents are wiser and know that's not possible. I think that's really the essential framing. And then there's an economic framing about costs and benefits and investment that I think holds as well. Another framing is we are diverse. No, one size does not fit all. We can't have one program, but we've got to do it universally. I like my child's pediatrician. Good golly, what a wonderful system. It's a universal system with individualized interventions.
I have a follow-up question on the Medicaid, and thank you for your system's perspective about what needs to be done. But I know in Massachusetts, where we have had for a long time pretty broad Medicaid coverage and insurance coverage for many things, they will not pay either Medicaid or insurance for these kinds of like parenting or mother-children interactions or parent, because it's not, quote, medical necessity. So my question to you is, on that level, given the ACA and all the stuff about prevention, how can we get a policy developed or some kind of systems change? I know this is a pretty, within the Medicaid and insurance system that looks at these issues as a medical necessity.
Yeah, it's a terrific question, and we could talk politics. Those of us who think Obamacare is a move in the right direction there, we could talk about capitated rates and getting insurers to think preventively. I don't think it's medical necessity. I think that there's just not a belief that these things work.
Mm-hmm. It's true.
I don't think we've convinced the world that psychosocial approaches to prevention of illness works. So I think we have to do a better job in that. And then it will be a medical necessity.
And I just have one comment around the screening out. Part of the problem we have with developing effective interventions for families like with substance use is that they often do get not included in studies because they don't comply, they don't show up, and therefore we don't have a lot of information about effective interventions for those families.
I agree. It is also the case that the success of a program like this depends on the effectiveness of those 400 agencies, and that's a real big if, right? But that's an important part of it. We have to have high-quality, effective substance abuse treatment, right, for mothers of infants.
Well, thank you very much. I think we've reached our time, and for ending a very productive morning with an incredibly helpful overview and general approach. Thanks, Ken.